Good morning, everyone, and I must say bon appétit, everyone, for this lunch symposium that we are very delighted to open today, focusing on especially the portfolio offered by BVI to manage our patients, especially for presbyopic correction. You may have all noticed around the different symposia that we have a huge range of different concepts available nowadays, and we need to find a way to make our proper choice for the best to offer to our patients. So I will be the first talking about this specific approach for trifocality and management of presbyopia, followed by some key experts in the field, going up to the so-called new generation of advanced monofocal. So let's talk about the trifocal FINEVISION IOL that we can call the pioneer in that range, and still today the gold standard. You will see why. When we talk about presbyopic correcting multifocal history, it's not an easy task, because we all know that the first generation were making this device quite unpopular because of some halos, because of some unexpected results, until we were able to manage the first generation called the AMO array as the first refractive multifocal IOL, and move on then after to the diffractive IOL. And it's in 2010 that the first trifocal was launched by Physiol with, we must say, great results, but with still big efforts to make to convince all our community to move back to this multifocality. So regarding the BVI, because now you know that BVI took the position and took all the different portfolio coming from Physiol, we can call the FINEVISION family. Coming from this trifocal, then when we went to the PODEF as a new design that would make the toricity available, because this lens, according to the design, was stable enough. Then we move on to the FINEVISION HP as an hydrophobic model, and finally the Triumph as a combination with, I would say, a trifocal and EDOF concept. So let's focus on all this evolution. We must say that the trifocal design, the first one, the so-called Mertens, I mean, in this family, was based on a very smart concept, the BNB principle, with a key role played by Damien Catinel. And it's a very intelligent concept, combining actually two diffractive optics, one providing an addition of plus 3.5 diopters, and the other one of plus 1.75 for the intermediate vision. And the beauty of the concept was actually to work well, but without too much loss and no more loss of light energy, since it was on an optical bench, no more than 12%. It was based on a very efficient IOL design with this continuous 360 degrees square edge and a small angulation that was good, even if it's made of an hydrophilic biomaterial, to be good against the PCO. And wearing these diffractive steps, you know that the curvature is just providing the power for far vision. And then there is a combination of apodization and convolution. With apodization, which is based on variable 8 steps from center to periphery, you will be able actually to provide a good distribution of light with not too much photic phenomenon, and that's thanks to the combination of the convolution to this concept of apodization. We know that the smaller are the steps and the higher is the add power, and the step height will determine the energy distribution between far and near. There is a high consistent outcome since 2010, and people need to know that. That means that if you look at the literature review, you will identify more than 50 peer review focusing on the results that has been provided by this lens. We can sum up with this, I would say, key messages. We do have halo, but I mean, it's only 6 to 10% of them that are spontaneously reported, compared to maybe more with some competitive trifocal IOLs. An average of 88% of spectacle independency has been reported, and you can go even upper if you have the chance to deal with toric version or if you do some enhancement. And we also know that the contrast will decrease under mesopic condition, but it's the case for any kind of presbyopic refractive IOL. What about the binocular defocus curves? Actually, it's a smooth plate, and if you look around all these different papers reported, you see that it looks all the same, and it's not too big, but it's a sort of plate that goes smoothly from far to near, meaning that the intermediate vision is not a third real focal point, but it's a range of vision that was already provided by this concept, this trifocal regular lens. In terms of outcome stability, actually we reported these 60 IOLs implanted in this, again, early period of 2010. And I must say that with this follow-up of a few years, as you can see here, the results are still there. We are close to emetropia, and stability is well achieved. Regarding the PCO, the survival analysis show that the micro-F will go for a PCO significantly at 20 months, when it's 5 years with an hydrophobic reference material like the ISOPURE. And you know that we will discuss later on the hydrophobic model for this lens. But it's still not good, since it's still good, I must say, since if you look at the rate of YAG laser per month, it's very acceptable to what we know with any kind of other trifocal lenses, including the hydrophobic model. Yeah, you can see here the comparison with the hydrophilic one available with Zeiss company. I have no financial interest in any of these lenses, besides being a clinical investigator for Physiol, for BVI. So why do we have to manage these different refinements? First, we need to know that today this lens is available in a preloaded version. The toric model is more than welcome, since we all know that for multifocal implantation, emetropization is just required. And we also know that 30% of our patients have a cylindrical component of more than 1.25 diopters at the age of cataract. So that makes sense to be able to correct astigmatism in those patients. The hydrophobic version, why? Because the majority of the surgeon in ophthalmology around the world do have preference for hydrophobic material around for, I would say, a better prevention potentially against PCO. But you may not know that it's a true challenge to transfer a multifocal design on hydrophilic model to an hydrophobic model. So we have to check if the quality of vision will be the same, if the predictability will be the same either. In terms of trifocality combined with EDOF, you know that it's a new step, and most of the laboratory also moved in that direction. It's the Triumph that has been launched 2 years ago around, and that was to manage maybe on a better way, thanks to this extended focal zone explored, a better potentially a tolerance to remaining error, and maybe a better quality of vision. So first, advent of toric model. Definitely that has to be a different design, a larger optic based on a pod platform that has been approved over 7 years regarding stability, well documented in the literature. Well documented in terms of capacity to provide good centration, good maneuverability, and very easy to manage operatively, because you can provide a clockwise or counterclockwise rotation, which is easy to deal with. A very high contact angle, you see here compared to some other hydrophobic material, it was even something very interesting to keep in consideration. Great stability, since we are much below 2 degrees of rotation. And for calculation, it's built on a Bulafia-Core formula to compensate the post-astigmatism effect based on a statistical measurement of it. And definitely, you see that in the literature review again, more than 94% of the patients were below 0.75 of absolute predicted results, which is really good. So you go on site and you do this surgery. As far as we are concerned, in my center, we did a comparative study comparing the panoptics with a podopteric that is actually presented here at the ESCRS 2021. And as you can see here, both are comparable and again below 2 degrees of rotation potentially. Then second refinement, the hydrophobic version, glistening free. That's something very important, based on a patent provided by Physiol with a 10 years follow-up. A rich tech, which is a very interesting property. As you can see, this wavelet on the haptics that offer no risk of sticky haptics, which is very also handy to manage during the surgery. And when you look at the literature review, as you can look here in the result that we reported on our evaluation with this lens, we are also providing a good predictability, even if we had to report initially some shift with some hyperopic shift that lead to an adjustment of the A constant. Halos and spectacle independency are also very interesting, as you can see here, very acceptable, since most of the patients have no severe halos, and most of them, more than 60%, are fully independent of glasses. What about the FINEVISION Triumph? The beauty is, again, based on hydrophobic trifocal model, so same glistening-free biomaterial. The beauty was a concept, as you can see here. It's a monotonic energy distribution, so providing you elongating depth of focus. Good results for far, good results for intermediate, maybe not as good for near. That was maybe a source of some disappointment, but I mean, we reported here during this meeting a good interest of using this lens after previous refractive surgery. As you can see here, the defocus curve is perfectly aligned on the energy distribution. But I mean, why, if you look at the global microscope, even if people like we all are here, the experts that will talk to you today are very convinced in that, it's only 4% of the market. So why you are still reluctant to use all these lenses? Well, we did this survey with the ESCRS in 2018 and 2019. And as you can see, most of your, I would say, limitations are based on the cost to the patient, on the concern of a nighttime vision, on the concern of loss of contrast sensitivity. Maybe also today we should add the loss of choice in concept, and which can lead actually to some confusion. It's why we are here today, to try to help you in making your selection. And if you look at the global distribution, it's still a huge place for trifocal. So that will be interesting to discuss with my co-moderator today. I still think that if you look for a true refractive purpose, trifocality is still the good concept at that time. And if you look among the trifocal IOLs available in Europe, we must say that BVI is still the gold standard because it does represent more than 50% of the market share. So if there is a decision tree, I must say we can try to put the different boxes, I mean, depending on look of quality of vision, best spectacle independency. But my sum up will be that, to me, there is no one single patient that is not using all distances. And a true happy patient is a patient that forgets about his eyes. So it's all about the discussion that hopefully we will open later on. So thank you for your attention. I hope that the lunchbox at the same time was a nice compromise between science and pleasure in life. And so with no transition, I invite our good friend Eric Mertens, who will explain an exchange about his own experience. So Eric, patient journey in my practice to achieve visual freedom.
Thank you, Beatrice, and thank you, BVI, for the kind invitation to give this talk. It's an unusual talk because it's not about the products, it's more about how the patients travel in my practice and what do you need to take in mind when you have these premium patients, actually. I'm a consultant for Physiol and BVI. Can I have the next slide, please? So what are the factors determining the result when you deal with those premium patients? First of all, the patient selection is very important. How to communicate with the patient makes a big deal of the experience. How to prepare the eye for the surgery And of course, which trifocal IOL to pick is also very important. What about the patient selection? Let's first discuss this. First of all, the personality is very important. Then the gender will play a role. I will go to that in more detail. Daily activities of patients are, of course, taken into account. And what is the eye? What is the astigmatism? What is the surface look like? And so on. So the personality, we all know perfectionists are not very good candidates, and aggressive and demanding personalities not as well. Who are good candidates? Easygoing people, people losing or not using their spectacles. Gender, sorry guys, but women are better candidates than men. And aggressive men are, of course, also poor candidates. What about the questionnaire? We always ask for their lifestyle. How long do they sit behind their PC? Do they drive a car? Do they drive a car at night? And so on. So they have to fill out the questionnaire before we can give them some answers, what kind of lens to choose. Which people are very good? Sport people, party people, farmers and outdoor workers, for instance. When picking the eyes, only pick correctable astigmatism, not irregular astigmatism, because with these high-performance IOLs, it's very difficult to achieve a good result. Hyperopic patients are, of course, ideal, and myopic eyes up to -3.5 diopters, because of when they can read without glasses nearby, are not so easy to satisfy. And the worse they start, that's a general rule, the happier they end, usually. What about patient communication? It's very important that you deliver the message, but patients are, because they're not knowledgeable, they're very sensitive to how you talk to them. So first of all, listen to the patient, not trying to answer all the time. Smile, be friendly, make them your friends, and never be arrogant, because patients will sue you when they do not like you. They will not sue you because of a suboptimal result or when you have a complication, but especially when you're arrogant and not trying to make your patient your friend or a good partner to talk with. Take your share time, or do it yourself, or do it by a patient coordinator, as I do in my practice. Set realistic expectations, of course, and do not hide away, do not push away the side effects. Show them pictures, videos of whatever animations, and of course, get a signed informed consent, like you will see halos and glare for at least 6 months and so on. So all those stuff needs to be signed so that the patient afterwards cannot say, well, I didn't know that in advance when you go to court. Create some trust. So a patient does not care what you know until he finds out that you really care. And even I see a patient twice if necessary, and do not charge for that second consultation, because this will create a very good relationship with your patient. What about the patient response? They often do not listen, because they're not knowledgeable, they're afraid, and bear in mind, the patient only remembers 20% what you said, and half of that 20%, so 10%, is remembered correctly. So only 10% is remembered correctly by the patient. We try to explain a lot, and we overload our patients in many cases with too much information. So I already pointed this out. There I have limited knowledge, and you have to explain it in a normal language, a normal down-to-earth language. Exceptions, of course, are engineers. They truly want to understand how that lens works and so on. But as you know, engineers are a little bit special as patients. What about expectations? Most people expect more than we can deliver, so we need to turn down our promises, and we need to over-deliver. They all want eyes like they're 20 years old. Of course, that is impossible. And we cannot predict how they will react to the side effects of these premium IOLs. Third factor is the eye preparation. It's a very important issue. And what do we do in our practice? So take your time to investigate the anterior segment and measure the astigmatism accurately. Not only the front surface of the cornea, but also the back surface of the cornea. You have plenty of good machines out there. This is the MS39, for instance, which I use routinely. And always have a look at the epithelial thickness map. When the epithelial thickness is not uniform across the cornea, then you have to find a solution, because there may be dyscorneal warpage, maybe have basement membrane dystrophy, and so on. So, or they have dry eyes. Just take care of this before you go to surgery and before you order your intraocular lens. Do a thorough anamnesis and investigate and optimize the anterior segment. And what difficult patients are glaucoma patients, because they used eye drops for so many years, and that surface is not healthy anymore. And look specifically for partial blinkers, because they will end up with not an optimal ocular surface. Look at the break-up time. There are also different machines who can help you with that. And like this, you can see that the break-up time in this case is limited. So what do? I treat it first. I give them drops or punctal plugs or omega-3 supplements or whatever you need to do. And I let them return 3 to 4 weeks afterwards and check it again. Because when you do not do that, you can end up with false calculations. This is one patient. Look at this. The average keratometry is 43 in before treating the ocular surface, and 44.23 diopters afterwards. So it's 1 diopter difference. And it can go up, I have cases of 4 or 5 diopters difference in severe cases. And also the astigmatism can be more or less, and the axis of the astigmatism can be different. So first treat the ocular surface before you order your intraocular lens. Now in our practice, what we do is we do the dry eye express, because time is money and we all have little time. We give them an OSDI or a speed questionnaire which they can fill out in the waiting room. We measure the non-invasive break-up time, which is a non-contact method. And we do also the meibography, because the meibography is very important to convince the patient that they have a problem. Although they do not have symptoms, when you take the picture of their meibomium glands and they see they have loss of meibomium glands, and you show them a normal picture, the loss of a body part is very traumatic to a patient, and they will understand that they have dry eyes without having the symptoms, and you have to treat it first before you do the surgery. So bear that in mind, because they will blame you afterwards when they come back 1 month after surgery and say, oh, I have itchiness, I have dryness of my eyes, it hurts, and they will blame you before the surgery. And then saying you already had dry eyes before surgery, that will make your life much more easy when you explain it before going to surgery. And of course, do a good axial length measurement. We have all those machines in our practices, and aim for a spherical equivalent within half a diopter of plano. And treat the astigmatism and use a toric high-performance intraocular lens. I use it from 3/4 of a diopter and more in my practice. And also, very important, of course, take your time to investigate the posterior segment. We all know that there is a much higher rate of retinal problems and retinal detachment when you do not have a posterior vitreous detachment, especially in myopes. So take great care, or send them to the retinal specialist somewhere else, or in your practice when you have it in your practice as well. But this is very important, a thorough retinal examination before this kind of surgery. During surgery, eliminate the astigmatism and compensate for the surgically induced astigmatism, of course. Do LRIs, or acute keratotomies, or a toric high-performance IOL. In these cases, it's very important to do a very good capsulorhexis. I use or the capsule laser or the femtosecond laser in my practice. And when you do a little bit larger rhexis, like 5.2 or 5.4, it will help you in the refractive stability, and it will diminish decentration and tilt in these lenses. Do the YAC early, provided the patient wants to retain, of course, that multifocal IOL. Correct always the residual refractive errors, because besides dry eyes, a second part of the dissatisfaction of a patient is when they have residual refractive errors. So treat them. You can treat it with the excimer laser, or you can treat it with add-on sulcus-placed lenses. And if the multifocal IOL replacement is required, do it as soon as possible. But of course, how long do you need to wait? How long will the neuroadaptation take place? So this is a thin balance you have to be careful with. The trifocal IOL itself, I'm not going into detail because Professor Cochener did a very good job in explaining to you. This still is the trifocal of Physiol BVI. In my practice, I used many of them afterwards, like the Acrylisa, the Symbiosa from Artis, and so on. And I still go back to the FINEVISION because it gives me such good stability and good satisfaction with patients. So in conclusion, do the patient selection very carefully. Get the time to know your patient or ask one of your staff members. That's what we do. The patient coordinator talks to our patients and get a feeling of what they want, what their daily activity is. Listen to them, explain the side effects, but in an understandable, down-to-earth way. Optimize the eye before surgery. Take great care in measuring the astigmatism and optimizing the tear film. Do, of course, butterfly surgery, and the IOL selection is, of course, extremely important. Thank you very much for your kind attention.
Thank you. Thank you, Eric. I think that, it's a very nice overview of what needs to be done to make the surgery successful in terms of information and selection. So let's move on now to a new generation of lens that we can call the monofocal plus or advanced monofocal. And it's our pleasure to talk, from far away, Dr. Renato Bilbao-Calabuig, who will talk to us from Spain about this ISOPURE. ISOPURE is the model offered by BVI as a premium monofocal. Optical principle and clinical results will be discussed by Renato after 18 months in his practice.
Good morning, dear colleagues. This is Rafael Bilbao from Madrid. Thank you very much to BVI Physiol for letting me doing this presentation on optical principles and our first clinical outcomes after 20 months with the use of the ISOPURE lens. These are my financial disclosures. I have no financial interest in any of the products mentioned in this presentation. I would like to start acknowledging my optometrist team, Paula Cardeñoso, Victor Tejerina, and Alba Fernandez. Without them, these studies wouldn't have been possible. As it has been previously mentioned before, in 2021, trifocal diffractive lenses are currently the gold standard for presbyopia lens correction. However, these lenses present some limitation regarding the anatomic contraindication of some patients, and due to some undesirable visual effects, this can be unacceptable by some patients or non-recommended for certain patients' activities. These trifocal lenses present also some logistic economic limitations for their implementation in some setting. And this is why in 2014 EDOF lenses were launched in the market. There are different types of and classifications of EDOF lenses. Or some of them present some different optical strategies and thereafter completely different performances. Hybrid multifocal EDOF lenses are low-odd diffractive or zonal refractive lenses. What we should call real or true EDOF lenses work either with small aperture diaphragm. There are some other models with some embedded optical devices in the center of the optic, and some other EDOF lenses work through a modification of the spherical aberration of the lens, of the monofocal lens. And into this category is how the ISOPURE lens works. The ISOPURE works through a modification of the spherical aberration of a monofocal lens, and we have to find out the balance between the increase in the spherical aberration and the subsequent increase in the depth of focus of the image obtained and the decrease, the relative decrease of the image quality that is obtained when there is a significant increase in the spherical aberration. The ISOPURE optic features a patented polynomial complex surface design across the full optic. It displays a centripetal progressively increasing dioptric map that extends the depth of focus in comparison to the monofocal predecessor. Besides, the ISOPURE was customized to provide a more negative spherical aberration in higher dioptric powers, usually implanted in hyperopic patients which usually have a more positive corneal spherical aberration. Regarding the optical bench measurements performed before the launch of the lens, Physiol found an extension of the depth of focus compared to the monofocal predecessor that was around 50% compared to the monofocal lens, and maintaining an excellent distance quality vision. Besides, the extension of the depth of focus was found to be almost pupil independent. In the USAV resolution target with the ISO 1 model, the ISOPURE lens offers a continuous increase of quality of vision between the distance and the intermediate vision. The ISOPURE is based on the MicroPure, the aspheric monofocal predecessor lens, with which we've had an extensive experience in Clínica Baviera, Spain, with over 7,000 implants with excellent visual, refractive, anatomic and PCO rates obtained. And the lens is manufactured in a glistening-free hydrophobic material. It comes in a preloaded cartridge. It has non-diffractive ozonal refractive profiles. There is no loss of energy and is as easy to handle as a monofocal lens. This is how we decided to perform a prospective clinical study performed in Clínica Baviera in Madrid. We initially started implanting patients with cataract and no other eye disease. An ISOPURE lens was implanted monocularly or binocularly in patients with a previous cylinder below 1.5 and with a target refraction that was 0 when it was implanted monocularly, and in one of the eyes between -0.5, -75 when it was implanted binocularly. These are the images of the first implant performed in Madrid in July 2019, 1 month after the surgery. Regarding the results of this study, we have now 25 patients, 42 eyes implanted with more than 6 months of follow-up, 13 female, 12 males. These are the demographic results. Regarding visual acuity, visual results for the distance vision, uncorrected in decimal vision was 0.84, corrected 90.95. Regarding intermediate vision at 80 centimeters, corrected intermediate was 0.64 at 66 centimeters, 0.6, and binocularly the vision results improve. In summary, we obtained very good outcomes for the distance visual acuity in the surroundings of 2020 with a monocular intermediate visual acuity of 2032 and binocularly of 0.75 around 2027. And what surprised us a lot was that many patients had a binocular near vision in the surroundings of 2040. Regarding the defocus curve, we obtain an extended defocus curve with a visual acuity superior to 0.2 logmar monocularly between the distance and 77 centimeters and binocularly between the distance and 62 centimeters. Regarding contrast sensitivity, both binocular, mesopic and photopic contrast sensitivity outcomes were found to be in the normal range for this age group. We also perform in patients implanted binocularly subjective questionnaires regarding the quality of the vision, and we obtained and we found that 90% of patients had no halos or glare, and the 10% of patients who had halos or glare, it was no bothersome. And regarding the spectacle independence, we performed this validated questionnaire also and found that 90% of patients didn't need glasses for distance or intermediate vision, and half of them were able to function comfortably without glasses at near vision quite often, not for extended time or difficult precision activities, but many activities were done comfortably without the need of near glasses. Regarding the results of the lenses implanted in Clínica Baviera, in June we performed a retrospective evaluation, and we had over 40 implanted eyes with 121 patients with defocus curve performed. And as you can see in the different locations in different cities of Spain, the defocus curve were very similar to the ones we obtained in Madrid performed in my patients. I have now over 135 implanted patients with different clinical conditions, and in patients who have no other eye problems, the defocus curve is the one I showed in the previous slides. Regarding the comparison between ISOPURE and the classic monofocal aspheric lenses, this lens provides an extension of a single focal point from the distance to the intermediate vision that can be enhanced with a certain mini monovision strategy when implanted binocularly without the negative effects and contraindication of monovision. There is a focus extension between 0.5 and 1.5 diopters, widening of the defocus curve, and a better tolerance to residual ametropia. We obtain, compared to the monofocal aspheric lenses, a greater spectacle independence, making virtually unnecessary glasses for the distance and intermediate vision, and a lower addition and less needed for the near vision of the patients. Compared to diffractive and zonal refractive multifocal or mixed multifocal EDOF lenses, this lens provides simplicity in the patient management, as there are fewer patient medical contraindication, fewer professional contraindication, fewer psychological contraindication from the patient, and a less demanding on any need for preoperative technology. We also spend less time explaining to the patients about the difficulties in the vision after a diffractive lens implantation. But we also have to remember that with these lenses we don't obtain a complete spectacle independence. We obtain a better compared to monofocal, but not a complete spectacle independence. Regarding the guidelines for the clinical management, as I mentioned previously, refractive target is between 0 and half a diopter in the other eye. Corneal contraindications, patients with high astigmatism can be a problem, and patients with a high preoperative negative spherical aberration, such as patients with keratoconus, presbylaxic, or hyperopic LASIK or PRK previously. And we don't think patients with severe maculopathies, severe optic neuropathies, or severe corneal diseases could benefit of this technology. In conclusion, the new ISOPURE lens seems to provide a very good distance vision quality combined with a visual improvement in intermediate vision by accentuating the EDOF effect without inducing any photic effect. Compared to the monofocal predecessor, we obtain similar distance vision, similar photopic and mesopic contrast sensitivity curves, of a clear improvement in the defocus curve, and a better tolerance to residual ametropia. A mini monovision strategy could enhance the results, and we obtain a high level of patient satisfaction with a very reasonable spectacle independence obtained. We need further studies to confirm these initial promising results and the positive input from these patients to directly compare these outcomes with the predecessor monofocal spheric lens, and to investigate the clinical performance of the lens in relation first with the physiologic changes in the pupil size, with the changes in the pupil centration, with different lens dioptric powers, and the results under scotopic conditions. This lens could very possibly be used in some ocular conditions considered contraindications for multifocal lens implantation, and this lens could be better addressed as a monofocal premium or monofocal plus lens with extended focus, as it extends uncorrected depth of focus and improves the spectacle independence compared to classic aspheric monofocal lens. Thank you very much for your attention.
Thank you. Thank you, Raphael. And so stay with us with your blue sky for a while, because we're going to open the discussion later on. Thank you also for raising the proper question regarding, this so-called advanced monofocal. And I think that with Dr. Vandekerckhove, if I pronounce it well, you will discuss on a very key issue. Should ISOPURE, for instance, replace our monofocal IOL over the last 18 months? That's something that we want to know.
Thank you, Beatrice. Good morning, dear colleagues. Thank you. My talk will be... Okay. My talk will be in three parts. First, I want to share with you the surgical approach in our clinic with regard to the ISOPURE lens. Second, I would like to talk with you about how we positioned ISOPURE in the clinic. And third, I would like to share some of the first data from a 100-eye retrospective study with ISOPURE. So as with most cataract patients in our clinic, we do bilateral surgery, not only for the convenience of the patient and family members, but also certainly within the context of high-tech lenses in order for the brain management to kick in much faster. We consequently apply mini-monovision, and we include up to 1.5 diopters of astigmatism. We reduce astigmatism then with opposite clear cornea incisions. And as it is the case for all lenses in the clinic, we don't use preloaded systems. We always rely on our AccuJect. Now, we talked a lot in the beginning about how to position ISOPURE. First idea would have been to position ISOPURE really as a new standard lens, so basically to replace our monofocal segment, to replace MacroPure. Then, of course, we would have ended up with a very high share of ISOPURE in the clinic and could have built only very small out-of-pocket costs to the patient. At the other end of the spectrum, there was the option to position ISOPURE as another high-end premium lens alongside with FINEVISION, of course, aiming at maybe only 10% of share of the IOL portfolio in the clinic. And then, of course, there's the in-between strategy, positioning ISOPURE as a modest premium. And basically, very soon we decided to go that way, aiming at around 30% IOL share. We achieved that share, and we even exceeded that 30% by how much I will show you on the next slide. We introduced ISOPURE in March 2020, and at that time we had in the clinic around 90% monofocals, the other 10% being trifocal and monofocal toric, a bit in a typical situation for as it is in any other clinic. And then after 8 months only, we achieved 30% share for ISOPURE. But then after, it continued growing and growing, and now today we have more than 50% ISOPURE, and at the expense of monofocals. Monofocals are around 40%, and the FINEVISION, the trifocal and the monofocal toric segment are more or less stable. So 800, I have implanted 800 ISOPURE within 18 months after introduction. That's a lot. A couple of factors contributed to that. First of all, of course, we have a lot of experience with the same platform. I have implanted more than 6,000 MicroPure lenses. As you know, MicroPure and ISOPURE are twins. Anatomically, they are completely the same, and yeah, it's MicroPure is a lens with very good visual acuity, precision. It's also very stable. I always say that you get actually a lens and a capsular tension ring for the price of one, and implantation is very reliable and smooth, and this is, I think, very important. Second, within the clinic, within the medical team, we very early on, we agreed on a positioning. We exchanged our early experiences, etc., at many occasions. And what helped a lot as well was that we tried all other EDOF lenses as well. So with all other EDOF lenses, I had like a series of 10 to 20 implantations, and we benchmarked all these newer EDOF lenses on a series of parameters. One of them, as you see here, the ease of implantation. The ease of implantation differs quite a lot between the lenses, and ease of implantation, it is an important factor and an important parameter as well. And last but not least, from the beginning, we decided early on to conduct an observational study, and so we accumulated more and more insights on the characteristics of the lens, and we grew our level of confidence. And I'm excited to show you the first data of this retrospective study. I would like to thank Dr. Tomagova and Dr. Elai for their contribution. So it's a retrospective trial, 100 cataract eyes. We excluded vision-relevant comorbidities, and we have followed up the patients for around 6 weeks. In terms of surgery, we applied the same as I have shown you before, as we do for non-study patients. Bilateral surgery, minimum vision, and we included up to 1.5 diopters of astigmatism, and we then corrected it with also CI. So I can tell you up front, the results are very good. Maybe unexpected, the distance vision is uncompromised. But we have, of course, an extended range of uncorrected vision, especially the intermediate vision was very good, but also the near vision was not bad at all, and it did not come at the expense of quality of vision. I'm happy to go into more detail. This is the EDOF curve, the binocular EDOF curve for 100 eyes. As you can see, we have 2.4 diopters of functional elongation. So this means that from a defocus of minus 1.6 diopters to a defocus of plus 0.8 diopters, we stayed within the range of functional vision being defined as visual acuities of 0.2 logmar and more. So, of course, in theory, this of course covers well distance vision, but also the full intermediate range up to a distance of 63 centimeters. So now how does that translate into visual acuities? First of all, and I think foremost, this is the most important parameter, especially with high-tech lenses like this one, the monocular corrected vision, and this was very good. Also the binocular uncorrected distance vision was very good. So with confidence we can say that distance vision was good and completely uncompromised. Of course, it's all about intermediate vision here, and intermediate vision was excellent. And also the near vision was not bad at all for an EDOF lens. So a nice extended range of vision. Now, when we asked the patients about spectacle independence, we used the PRISC questionnaire, and unsurprisingly, maybe the more than 90% of patients reported that they were very comfortable at distance, but also at intermediate. And we even had 40% of patients reporting that they were very comfortable at near vision without any correction. Now, again, does that come at the expense of quality of vision? We have confronted all the patients with pictures of the three photopic phenomena, glare, halo, and starburst. And actually, only 1 month after surgery, there were very few patients reporting visual disturbances. For example, if you look at halo effect, only 7% of patients reported to have seen halos, and this is very low. especially taking into consideration that A, we have confronted the patients directly with the pictures, B, we applied mini-monovision in all patients, and C, this is about 1 month. So if you look in the literature, for example, for trifocal lenses, you will see that up to 90% of patients within the first month after surgery will report halo effect. 90% will report halo effect. So I would say these are very robust data from a retrospective study. The question here is that it, or do we still need something more? And I think we still need something more. The real deal, ladies and gentlemen, the real deal is always a direct head-to-head comparison between equal contenders, something which companies are most of the time not very fond of. And we are about to start such a comparison. We will compare ISOPURE with another next generation EDOF lens in a prospective way in 130 eyes. We are working very hard, and we are confident that we will be able to present you the first data in 1 year from now. Thank you.
Thank you, Christophe. Very promising. So I think that we have time for discussion. I don't know if there is any questions coming from the audience. Actually, we are all sharing the same view. First of all, the confusion that may be induced by these different families of lenses, we should definitely redefine, I guess that you would agree, this huge group of so-called EDOF that are different by concept, and maybe to a certain extent, related to the marketing model in terms of economical issue. So I think that you would agree that whatever they are, these advanced monofocal do have a portion of EDOF effect. We are extending something. So my first questions to you three would be, I understood that you are positioning the ISOPURE as a potential substitute for our regular monofocal, regarding the fact that if we look to the results, we get the minimum effect that we can get is a good preservation for far vision, and the best is some increase for intermediate vision that can depend on many parameters. So, it's not maybe as robust than any other rear refractive surgery than the trifocal. So, do you think that definitely, according to the current knowledge that we have on this lens, what are still the contraindications? Because you were planning, Christophe, to maybe take the place of the monofocal. You call it monofocal plus. We understood with Raphael that there are still contraindications. I'm curious to know about presbyLASIK with asphericity modulation that we want to keep. So can you just pick up the current contraindication that you are having for this advanced monofocal? Yeah, sure. It's a question open for the three of you.
So I think we have now a lot of experience after 800 implantations. I really think there's almost no medical contraindication not to implant an ISOPURE as compared to a monofocal. There are some, for example, hyperopic LASIK, but there's almost no medical contraindication. Even in patients with some risk factor, or even early glaucoma or retinal problem. Currently, we are opening our field of indication, so we are doing LASIK patients with early, even moderate AMD, clear lens extractions, early glaucoma, etc.
Clear lens extraction, interesting. So, in that case...
We're also playing with different refractive targets. So, for example, we have patients that really want to have optimal vision near and intermediate, so we aim then at minus 1.5, and we have patients perfectly at ease at computer work, reading, and even very small print or nearby 25 centimeter work. So,
You would agree on that, Raphael, from where you are? Because you mentioned the list of contraindications. You may be on mute.
Yes, I don't know how I can... Hello?
Hello.
Hello, can you hear me? Hello, Beatrice and the rest of exposers. Thank you very much for the invitation to Physiol. I would say there are two groups of patients in which I would not implant ISOPURE. First of all, due to the high negative spherical aberrations, I think patients with a cornea treated previously for hyperopic LASIK or PRK, or for presby LASIK, in which they have a very prolate cornea with a high negative spherical aberration,
of course,
they could get a worse quality of vision, and this is why I'm not implanting them in these patients. Whereas on the contrary, patients previously treated for myopic LASIK or PRK, I have a certain experience and they are getting extremely good results. This is a contraindication. Patients in which I don't think this technology would make a big difference compared to a classic aspheric monofocal lenses are patients with severe macular or optic neuropathies in which the modification of an aspheric aberration would not make a difference in their quality of vision. So patients with a severe maculopathy or severe optic neuropathies, I don't think they would benefit. They're not really contraindication, but you're not going to bring anything special to them in this, in regards to, or in comparison to a classic aspheric monofocal lens.
Yeah, so I fully agree, and I think that it's not a contraindication. There is no effect. So do you think that, I mean, we got the proof that, Eric, that with the time, with the aging process, the patient should go very well with this lens along the life, maybe with less concern than with the classical diffractive lens, what do you think?
Well, I have, first of all, I must say that we need to, because we're talking about EDOF and monofocal plus and so on, and in my presentation, I was the advocate of communicating to the patient in a different way, in a lower level that they understand. So,
by the way, we should also communicate to the colleagues with the same way. Yeah.
So, we're working with a group, with Shiraz Dayar, Francesco Caronis, and we're thinking about introducing like single focus, increased range of focus, and full range of focus. So the ISOPURE is an increased range of focus. The FINEVISION is a full range of focus. My practice is, when patients come to me, they want it all. I was raised as a refractive surgeon, so you want to correct that vision with the patient, and that's why my patient population is like. So, and I must say, I do implant even FINEVISION and Triumph in post-hyperopic LASIK patients. They do extremely well. So I urge you to try it as well. Of course, the hyperopic laser treatment has to be well-centered and the surface of the cornea has to be pristine. But these patients, they do extremely well even with those full range of focus lenses, and they will do also very well with the ISOPURE lenses. So I urge you to try it. Because you will be amazed how good they will see for close-up because of the increased spherical aberration, because of the ablation, the hyperopic ablation done by LASIK.
Actually, I fully agree. As I mentioned, we are presenting a paper of Triumph after refractive surgery. What I like in this hybrid version, which is this combination of a trifocal regular, as you mentioned, full focus, but I mean, with a specific focal point extended to an area, it's much more tolerant to some remaining error that you may achieve because of the lack of accuracy for calculation after refractive surgery. But I fully agree. So one quick question, because I think that we need to close very soon. Regarding these trifocal lenses, have you moved, the three of you, to the hydrophobic model, or do you still find a place for hydrophilic compared to hydrophobic?
Sorry, yeah, go ahead, sorry.
Thank you, no, sorry. My preference regarding trifocal diffractive lenses are hydrophilic due to the, I think, slightly better quality of vision regarding the material. And of course, taking care that the patients may not need in the future any surgery that may need the introduction of any kind of gas or air inside the eye. But regarding the quality of vision, I'm very, very happy with the micro F platform. and the hydrophilic material.
Christophe?
The same for me. I think the visual quality is unbeaten, the visual quality of the hydrophilic. I do use now 100% hydrophobic FINEVISION, not because of the PCO issue, but mainly because of the stability in the capsular bag, which might be important in some cases.
Yeah, especially for the toric version, for instance.
Yeah.
Eric?
So I'm full hydrophobic now because I'm in love with the hydrophilic material, but I do mix and match the Triumph with the FINEVISION. So I do the Triumph in the distance dominant eye and the FINEVISION in the near dominant eye. Of course, when we have the near dominant eye the same as the distance dominant eye, I put in the FINEVISION in both eyes, but otherwise I do the Triumph in because they have a little bit better intermediate vision and the combination works beautifully. And because the Triumph is hydrophobic platform, I'm not going to mix and match also the material, so that's why I'm full hydrophobic.
So I think that we can assume that BVI did a good job in the field of cataract surgery and in offering us, all the portfolio that we can imagine. So we just now, and thanks to you guys, we understood the way we could position all of these lenses in the offer that we are making to our patients, which is basically to try to offer them the best. Again, if I may come back to my conclusion, we know that the happiness for patients is definitely to forget about his eyes. So we need definitely also to try to achieve that goal according to what we have available nowadays. So there is still space to improve. Yeah, one question from... Yeah, sure. I'm sorry. We are in the full darkness. We hope that you are 1,000 behind us, but yeah.
Hello? Yes?
Yeah. Yes, sir.
I have a question concerning asteroid hyalosis and syncytial scintillant. Are those sort of contraindications for treatment, for implanting a multifocal, or what is your opinion about that?
If I understood...
Syncytial scintillant.
For sulcus, yeah. Okay. Actually, these lenses are designed to be put in the bag. So,
no, sorry, I didn't express myself clearly then. If you have syncytial scintillant, these unclear floaters around in the vitreous, syncytial scintillant or the asteroid?
Cholesterosis bulky.
Yeah. Sorry. No. What's your opinion about that?
Well, first of all, we do not see that often. And even when we see that, we discuss this with the patient, that the phenomena they have pre-op, they will stay afterwards. And then what I explain in my talk, just be honest about it, it's there. You could send them to a vitreoretinal surgeon to do a vitrectomy first, if necessary. So just be honest. They will see it, of course, they will have some influence on it, but it's not a contraindication, but just fully disclose it before surgery.
Many of these patients, they don't really experience any symptoms before.
Yeah, that's true.
But
especially if they do have a true cataract. Yeah.
Sorry, yes. So you would expect, you see also if you have the vitreous body, it's falling apart, you have many symptoms after implantation of a trifocal. And, well, I would assume that there is a greater risk that they will experience these symptoms after implantation of a multifocal lens.
Yeah, absolutely. But I fully agree. First, that's a good case for, putting in the discussion the proper indications of a trifocal. They are so demanding of the good transmission of light that there is no doubt that it's maybe not the good lens in that situation. Otherwise, as Eric mentioned, there is still potentially an indication then after for a vitrectomy with a small incision. Yeah.
But could it also be an option to put in an ISOPURE on one side? And
absolutely.
Okay.
No doubt on that.
Yeah. Okay. Thanks very much.
Yeah. Okay, so I think that if there is any questions, can you confirm no hands? Okay, so I think that it's time to conclude and to say thank you to our expert, to wish to Raphael a good day. Please send us some sun, Raphael, because I think that it disappeared here. And we wish you, we wish you all, first of all, to accept and to integrate all of these new advanced optics in your routine practice, because I mean that's mandatory now to think about the evolution, the progress that has been made in this area. And so we wish you a great day and a very nice meeting. Enjoy ESCRS and enjoy Amsterdam. Thank you very much.